give it one more minute and then get going. All right. I found some an old EP conference from 9 years ago. Some good old chestnuts, as it were. So here we go. All right. And by the way, this is a question, very similar question was asked of me on my board examination. So this is a 14-year-old, I'm sorry, 12-year-old fenestrated Fontan patient during catheterization for closure of a fenestration with an Amplatzer device. What is the rhythm disturbance that you are seeing here? These are a 12-lead electrocardiogram, and this is a catheter that's been placed in the patient's high right atrium. So why don't we see if Dr. Capon has any thoughts on this?
Dr. Pass. So just trying to orientate myself with the leads here and then looking at the catheter in the high right atrium. So I'm first trying to isolate some P waves. It looks like I can't really see a P wave in the first beat or after the first kind of QRS. And the second beat, it looks like there is a P wave followed by a QRS.
Talking about this P wave here?
Yeah.
Uh-huh.
So I didn't see one with the beat prior.
Mm-hmm. No, I don't show you very much before.
Yeah.
But yes, I agree with you. You don't obviously see P wave.
So
Sorry that it's a little unclear. Let me just also tell you the ventricular rate, let's just say for the sake of this conversation, is 60.
All right. So I can't really tell in the next couple beats if there's a true P wave. I don't really see a clear inflection like I do see in the second beat, in the third, fourth, fifth, and sixth. So perhaps these are just ventricular.
I would remind you that you have a high RA catheter also.
All right, thank you.
So it's always a good idea. I agree with you 100%, Ivana, that looking at the 12 lead and trying to orient yourself and see if you can figure it out by the 12 lead is always a good idea. And I would encourage you that if you're taking an examination ever or standing at the bedside and someone who has atrial wires, for example, I still, as you all know, would always favor as your first test the regular 12 lead and looking at the 12 lead to see if you can figure it out. And the reason that I recommend that is because that's the test that you and I look at the most of all tests. So you would always want to lean on the thing that you're the most experienced with, right? It's like an echo. If you asked Miwa Geiger, you had one test to assess a patient, she would probably say, I'll do an echocardiogram because I'm really, really good at echoes. And even though maybe other tests might be better, I wouldn't be able to perform an MRI, or I would be less good at looking at MRIs than, say, Nadine is. So my point is just, we look at 12 leads all the time. So I fully agree with your decision to look there, but I also would comment that in this case, it's a little challenging to interpret because there's a lot of baseline artifact. And I gave you a kind of a crappy tracing that's out of focus. I apologize, but back in 2015, we didn't have these high megapixel cameras we have today, these fancy things. So
looking at the high right atrium catheter, thank you for again mentioning that it is there for me to look at. It does look like, where that P wave was that we initially thought we saw, there is a deflection in the high right atrium, and we see that kind of trending through. So there are P waves, although they don't particularly seem to be associated with the QRS that you can also see, if I think I'm on the right track.
Okay. I mean, let me ask you this. Do you have any sense? Okay, I'm sorry to interrupt you. Just keep going. Keep going. Sorry.
So I'm either wondering if there's a prolonging between the P and the QRS,
Yes.
and then a drop versus block. But I think we're looking at a Wenke-Bach type picture.
Yeah.
So prolonging of our PR and then a sudden drop.
That's right. I agree with you. So you have here, here's the A. So this is the A.
Yeah.
Again, always go back to what you know the best. So we all know how to look at 12 leads. And so these are obviously the QRSs. We may be having trouble seeing the P waves, but there's no question which is what the QRSs are. And so, and remember that even though the catheter is in the high right atrium, first of all, it's a Fontan patient. So you're never going to, so it's hard to get atrial polarization, but usually when you're in the atrium, you can sometimes get far field ventricular electrogram. So if we look here when the QRSs are, you can actually see there is an electrogram on the high RA catheter, which seems to correspond with that. But then the atrial signal actually is larger, right? Much larger, and that makes sense because you're recording directly from inside the right atrium. And this is probably a patient who has, do you think this is a lateral tunnel Fontan or a extracardiac Fontan, Ivana?
I'm going to say
we're recording electrical activity in the right atrium there.
So probably a lateral tunnel.
Yeah, it's not that easy, I would think, to record atrial electrogram lateral from an external conduit, right? Because you have a piece of Gore-Tex tubing which is between you and the atrium. Now, I think you might be able to record. Also, you might be able to record at the bottom or the top, where the anastomosis is, at least maybe near the IVC, but this is almost certainly, when you see such a big electrogram, this is probably someone who either had an old style Fontan or a lateral tunnel, because remember that in the lateral tunnel, the surgeon incorporates the lateral wall of the actual true right atrium. So you can, in fact, record from there. So yes, I agree. So we see that the PR, if this is the A to the V interval, is getting longer, and then there's a drop beat, and then the A to the V is getting longer, and then there's a drop beat, and so on and so forth. And the other thing that's a clue is that when people have Wenke-Bach, oftentimes there is grouped beating. And you see how there's two beats together, then it seems to be a pause, and then two beats together and a pause. This is when you see that type of a pattern, 2 or 3 beats together with a pause, you should always in your mind be wondering if it's possible that this is an example of Wenke-Bach. Okay. It's also clearly not complete heart block, right? When you see more P waves than QRSs, one often will think that you're in complete heart block, but the fact that there is a variability of the R to R interval is often a very good clue that there is at least some conduction and that there is not complete heart block. So by definition, this had to be at least second degree block, but not third. And so this is a patient who has Wenke-Bach. And of course, we would need to know what the circumstance was of this. In other words, is this, for example, an example? So the atrial rate is approximately 110 beats per minute. Most people should be able to conduct at that rate. And we can sort of tell that in lead 1, the P wave is upright. We can't really see the P wave very well in F. But the question is this sinus rhythm or is this some kind of atrial flutter? And then the other question is always, whenever we do a cath, have we caused this? Did the patient conduct well before? And did we screw things up? Particularly when you're closing a fenestration, the guide wire has to go through the fenestration into the left atrium. And there's always a chance that you could bang the conduction system in the process of going through the fenestration. So one needs to be careful in terms of wire positioning, and also remember that in order to deliver a device, we have to deliver a fairly sizable sheath through the fenestration that also could bump into things that you don't want to be touching. And so it's also possible that the device itself is touching something on the other side of the fenestration. That would be unusual, but not hard to imagine, at least. So the interesting question would be, if you saw this immediately upon closing the fenestration, in other words, you open the left atrial disc, pull it up against the wall of the Fontan, and you see this, do you take the device out, or do you leave it and hope that it will resolve? And that's always a challenging situation. I remember once in a different case, I closed a very large ASD in somebody, and they ended up with, right on the table, they had first degree heart block with a PR of about 250 milliseconds. And it was very, very early in the Amplatzer experience. I think it was actually our first case after we had had a proctoring by Dr. Hijazi, who at that time was the guy who did most of the proctoring in the US of that device. And I actually called him with with the device still attached to the cable to ask his opinion on whether I should leave it in or take it out. And he recommended that I leave it in on the theory that if overnight it got worse, we could always take it out surgically and close the ASD, and it would be likely that the conduction would recover. And if it were to remain in first degree heart block, then his attitude was that that was still better than having open heart surgery, where one could get first degree heart block anyway, although it's unusual but not unheard of. So we left the device in. Patient went home with a PR that was a little slower than the one in the cath lab. I think it was about 210. And interestingly, his cardiologist for many years would tell me that on Holters, he would go between fast and slow pathway. So we probably were pushing a little bit on the patient's fast pathway, but not enough to cause heart block, but enough to cause changes between one and the other. He never, at least I know, I followed him for at least 10 years afterwards, and he never had anything higher than first degree heart block. Okay, very good. Let's move on to the next case. All righty. This is a 16-year-old who's in the emergency room and is complaining of dizziness. So let me ask Dr. Kalis what she thinks is going on here.
All right. Good morning, Dr. Pass.
Good morning.
Okay. So
they're on the bed. They're talking to you. They're saying, boy, do I feel dizzy.
Okay.
Let me ask you a question before we get any further. Does that surprise you that the patient is awake and talking to you with this rhythm and this rate and is telling you, I don't feel good? In other words, would you think that the patient had to be obtunded and on the verge of death?
I think on first glance, perhaps, but I guess I'm not surprised that there is some sort of he's dizzy, he might be feeling like he's about to syncopise or something like that. And so
Right. So
I'm not
I think
surprised
it's
at this point.
important. I think it's important to note that you can have a rhythm like this and be conscious. Okay. Now, is he going to be conscious for a long time like this? Probably not.
Probably not.
Does the fact that he's conscious mean we don't need to move quickly in our assessment and management of this? No. But my point is simply, you can have rhythms like this and patients can still be conscious and talking to you and smoking and joking. And so don't let the fact that the patient is still awake deter you from your rapid assessment and management. So I'll stop there and go forward. The reason I mention this is because I've seen patients, I've seen doctors, and you guys have heard me complain about this before, where a patient has a rhythm like this, the doctors get very scared. The patient is awake and talking to them, and they literally electrically cardiovert the patient awake. And because they're so frightened by what they're looking at on the electrocardiogram. But that is always the wrong thing to do. It is not wrong to be worried. It is not wrong to assess it and to rapidly manage it. But it would always be wrong to cardiovert somebody who is awake. You always want to either wait until the patient is unconscious or make them unconscious with some approach of anesthesia. So I'll stop there, and sorry to interrupt you, Maya.
No worries. Okay, so I think the first thing I noticed that was that we have like a fast and wide rhythm.
Uh-huh.
So the first thing that I'm worried about is a ventricular tachycardia.
Okay. Is it irregular or regular?
I would say it's irregular.
I would say you are correct, right? I mean, look at these. These look kind of regular, but then there's this sort of pause, and here's 2 beats in a row. And I mean, look at this right here. This is definitely not there. Our intervals here are not fixed at all. So yeah, so this is an irregular rhythm. Is it regularly irregular or irregularly irregular?
It looks like it's irregularly irregular.
Correct. There doesn't seem to be a pattern of the degree of irregularity. Okay, so let me just summarize what you've said so far. You said it's a wide QRS tachycardia. It is irregular, and it is irregularly irregular.
Mm-hmm.
So what do you think that is,
I think the
Dr.
other thing on my differential is going to be AFib with like a rapid ventricular response.
Would there need to be a condition of another? Can someone's AV node conduct this fast? I mean, some of these our intervals are like above
With
300 beats per minute, right?
and then also pre-excited.
Right. You would have to be pre-excited to be able to conduct this fast because the normal human AV node in a 16-year-old cannot conduct it, over 300 beats per minute. Okay, so the patient is awake and is talking to you, and but is saying, I don't feel well in this. So you're in the emergency department. You're actually just walking by the emergency department, going to get an ice cream, and someone in the ER says, oh, wait, there's the cardiologist. Let's bring her in. They bring you in there. They're all thrilled. There's a cardiologist to help them. You look at this. You're very upset because you wanted that ice cream, but you're now deciding, what am I going to do? So what would you advise the emergency staff to do at this point?
So I think he's conscious right now and awake, but on the verge of potentially losing consciousness.
Yeah.
So I would get everything necessary for a cardioversion.
Okay.
In the case that he loses consciousness, you could cardiovert him quickly.
Okay.
And then at the same time, perhaps prepare like if we need to do like a sedated cardioversion.
Right. So what I would do is, okay, let's say there is no one who feels comfortable to sedate this patient in the emergency room. So what would you next do? Is there any medical way you could manage
We
this?
could do medical cardioversion.
Okay, and how would you do that?
So I believe for medical cardioversion, we often use flecainide.
Okay, so you could give the patient flecainide, but it would be a little unusual in somebody with this fast of a rate where you're so worried about potential, right? This is almost certainly pre-excited AF. Okay, so very important. If you see an irregularly irregular wide QRS tachycardia, you should consider it to be pre-excited AF. It's every bit as dangerous as VT or VF because it could degenerate into that at any moment. Okay.
Or I
So
think
you would definitely want to cardiovert. If you cardioverted, would you synchronize to the A or the V?
You would be doing synchronized cardioversion, so I'd synchronize to the V.
Right, because you don't want to put a R on T, right, when you're defibrillating the patient, or well, you would be defibrillating them, right, because you're trying to terminate atrial fibrillation here. So this is rapidly conducted AFib. Now let's say, what you would do is you would be calling anesthesia or calling the ER physician if they feel comfortable to sedate the patient. And so the first thing you would do is call anesthesia. Second thing is you would put the pads on the patient. And how much energy would you give the patient? So let's say the patient is 100 kilograms. And you're pretty confident that you're in pre-excited AFib. Dr. Pass told you if you see an irregular wide QRS tachycardia, that it's AFib, pre-excited, rapidly conducted AFib until proven otherwise. So you're now, the emergency room physician has come. They've given a dose of fentanyl and Versed. The patient is unconscious. You have 2 minutes before he wakes up. So how much energy do you want to give synchronized?
So usually we do like 0.5 to 1 joule per kilo.
Right.
So if he is 100 kilos, we could start with 100 joules.
Right. So you could give 1 per kilo, on the theory that one shock is better than two, and 1 per kilo is usually a safe dose. And you're sedating in the ER. Okay, let's say for the sake of conversation that there is not a defibrillator available, or alternatively, there's a big power outage and all the plugs, including the red plugs, are not working. So is there any medication you could give a patient like this, IV, that might help?
I think we also use diltiazem
No, no, no.
for
Diltiazem. You're
AFib.
right. You're right that in someone in AFib who is not have WPW, you could give
Mhm.
diltiazem because it would slow AV conduction potentially and cause a slower ventricular response rate. But for people who have this type of conduction, which is right, and we've decided that at this rate it cannot be going down the AV node. We would not want to give it because it could enhance accessory pathway conduction and induce VF. We're worried about this turning into VF because if you have enough RR intervals happening this close together, one of them is going to cause VF. So what else could you give?
Could you do amia?
You could give amiodarone, that's one option, but which would be reasonable, but it may not work fast enough, but absolutely you could give amio. What else could you give?
Um,
There's one classic agent that is the most common one used in this circumstance.
is it procainamide?
Yeah, procainamide will cause slowing of conduction in the accessory pathway, and that's the classic treatment. So if you were in the ER and you saw this and the patient were conscious, what I would probably do is I would call anesthesia. But as you and I know, that might take 5 minutes to happen for them to come down and get set and feel comfortable that they can safely sedate a patient. And I might start giving a patient a dose of procainamide, give them 5 to 10 per kilo as an infusion. Now, in an adult, the dose is different. I think it's 50 milligrams or 100 milligrams, but you could give a dose of proc while you're waiting. And the benefit of the proc is it should slow the ventricular response rate. It might even terminate the AFib, but it would almost certainly slow the ventricular response rate and turn this patient into a much less dangerous form of AFib. So let's look at what happened here. So the patient is in this rhythm, and right here, by the way, I'll give credit to the Tehran Arrhythmia Center, where it got this tracing 15 years ago, or not that long ago, 10 years ago. They deliver a shock here of some energy. I don't know if it says what they gave. I don't think it does. And then something happened here. So what do you think happened here?
Um,
Something bad.
oh, I see. Okay, so they delivered a shock. Um, well, now it looks like they're in VF.
Right. So how would you explain that a shock turned this patient who was in this rapidly conducted AFib into VF?
If they shocked on a T wave.
Right. So basically, it means that they were not properly sensing. Okay. And we can actually see the sensing here, but you can tell that it's missing some, right? Like there's probably the QRS is off the page here, but probably there was a QRS here. Here's a QRS it's not sensing. Here's a QRS that it's not sensing. There's one here. So the sensing is poor on this. And so basically they put a shock on a T wave and induced VF. So what would you do then if you saw that? So now you're in the ER and all you wanted to do was to get an ice cream cone, but now you've induced VF in the patient. So how are you going to get yourself out of this situation?
So then you would need to defibrillate the patient.
That's right. You would need to defibrillate them. And how much energy would you give the patient to defibrillate them?
I would give him 200 joules.
Which is 2 per kilo. So you're going to treat him as if he has VF because that is in fact exactly what he has. And that's what they do here. This is the shock here. I don't have the rest of the tracing, but presumably he went back into sinus rhythm and was pre-excited. Okay, very good. So now you're very happy because you finally got him out of it. You can go get your ice cream cone, but they're asking, well, Dr. Kalis, what should we do with this patient? This seems very scary and dangerous. So what would you do now? The patient is, let's say it's a Friday at 4:30, which is always seems to be the case. And what are you going to do? What are you going to recommend for this young person?
Well, I guess we know that he has a high risk WPW.
And why do you say that? I agree with that statement, but verbalize why you believe this is a high-risk WPW patient.
Because the concern with WPW is if you have AFib, you can conduct rapidly,
Uh-huh.
and that's what happened.
Right. What is rapidly, by the way? What do you mean by rapidly? I agree 100% with everything you've said, but what do you mean by rapidly? This is rapid for sure, but what's the line in the sand of rapid when we talk about WPW?
I think we um I think we usually say, I don't know if there was like a specific cutoff for heart rate.
It's basically cycle length 250 or a rate of about 240, 240 to 250. If you can conduct at rates above 240 beats per minute or 250 beats per minute in AFib, you are at risk for sudden heart. That would categorize you as a quote unquote high risk WPW patient for sudden cardiac death. And so, in theory, if we were going to properly assess every patient who has WPW when we're in the cath lab, we would induce this rhythm in everybody and then see how fast they conduct. Now, the problem for us is, first of all, in young people, it can be very challenging to induce AFib. Just as in older people, it can be very easy to induce AFib. In young people, it can be very challenging. And sometimes we have to pace at rates of, 300 beats per minute for 15 seconds before we can induce it. And oftentimes, because young, healthy people don't have AFib, you induce 6 beats and then it terminates on its own. And I'm sure you've seen that both with Barry and I do cases that sometimes we inadvertently induce AFib during regular testing. Almost always it stops on its own within about 30 to 60 seconds. So first of all, it's hard to induce. And then the other problem in the EP lab is that our patients are sedated. They're under general anesthesia usually. Some labs don't use general and just use heavy sedation. But the bottom line is, how a pathway or an AV node conducts in the setting of sedation, it's not clear how that relates to how they would do if they were awake. This is real life. So if your patient awake is conducting at 300, it doesn't matter what you then obtain in the cath lab. This patient has proven that they can have high risk and they're at risk to die suddenly from Wolff-Parkinson syndrome. And so a strong argument could be made that if you were going to do an EP study on this patient or ablate this patient, that you don't even need to test this patient. You could just go straight ahead and just map and ablate it because you've already demonstrated clinically that this patient is at risk. Another scary thing about this is it is not uncommon that a patient like this goes to the cath lab with these tracings and then in the lab has a low risk pathway, suggesting that our ability to predict this in the cath lab is not 100%, which is why some people believe that we should attempt to ablate all the WPW we see. I'm not sure I agree with that, but there are arguments to be made for that. It's not a completely unreasonable view at all. Okay, so Maya, it's 4:30 on Friday. What are you going to tell the ER? What should they do with this patient?
So, since this already happened and we know he has a high risk pathway, I don't think he would be able to go home before he has
He's telling you,
like,
though, he has a soccer game the next day and he feels fine. He's back to normal.
yeah, I would not recommend that he play in his soccer game.
Okay, I agree with you on that. So you admit him to the hospital, and what are you going to do for him, Maya?
I think we just kind of need to watch him. Like, I think he'll need to get an EP study, an ablation.
Right. He needs an
Um,
ablation, this guy, right?
yeah.
Because he's demonstrated that he could die from this. So so the options are he could just stay in the hospital until such time that he could be ablated, and he's protected by being in the hospital. Alternatively, you could put him on medication to potentially lengthen the refractory period of the pathway temporarily. So what agent could you use in somebody like this, possibly?
You
If
could
the
use a
patient said, I just can't be done on next week. I'm being inaugurated as the first 16-year-old president, and it's next week. I can't go. So what would be the other option?
you could use a beta blocker.
No, beta blockers would, it's a good question. Beta blockers are theoretically can enhance pathway conduction by slowing AV nodal conduction. Now, as you all know, in pediatrics, we very routinely put patients with WPW on beta blockers to prevent them from having SVT. But in the adult world, and this patient's getting close to it, there's a strong belief that beta blockers may actually increase risk for patient in terms of sudden cardiac arrest. So beta blocker would not be, we could not confidently say that would protect the patient. Any other agents you could think of that you could put the patient on?
I guess you could put them on like amio.
Yeah, you could put them on amio, pretty big gun, but the problem with amio, though, of course, is it requires a long load, right? Like 5 or 6 days. And you would typically do that in the hospital, but amio would be fine. You could use procainamide. Proc does come as a oral agent. You don't see us doing proc almost ever orally in anybody, and the reason for it is the reason is that procainamide comes as a very large dose, like the smallest dose is like 1,000 milligrams. And it has a short half-life. There is a long-acting variety, but even the long-acting, I think, is at least twice a day. I think it's called Procan Bid. So you could give, I guess for BID, so you could give somebody Procan Bid. That's what they would have done in like 1990. And in an era before catheter ablation, a patient like this would be taken to the cath lab. They would give them a dose of IV procainamide, and they would retest to see if the pathway was conducting slower as proof that proc was lengthening the effective refractory period in the patient, and then they would put them chronically on procainamide. So that would, when the other option was surgical ablation, which was obviously a very big deal, and by the way, wasn't offered in most centers. And then another option would be flecainide. You could put someone on flecainide. Flecainide also can lengthen the effective refractory period of pathways. So any of those options would be reasonable, at least as a temporizing suggestion until such time that the patient had an ablation. But I think in 2024, the correct answer to what you would do for this patient would not be any of those agents. It would be ablation for somebody who presented like this. So important when you see a irregular wide QRS tachycardia in a child, you should always be thinking of VT is always an important concern, but also rapidly conducted atrial fibrillation. All right, any questions about this? All right, I think that was a hard one, Maya. Good job. I think we'll stop with that. Hope everybody has a wonderful day. See you at Sinai in a little bit.
Thank you.
Yeah.
Thanks for the pass.
Thank you.